Hello, everyone, and welcome to our module on evidence-based medicine. Evidence-based medicine is a very popular term these days when taking care of patients, and it's likely that one or two questions about this will come up on your Step 1 exam. These questions are very easy points if you just know a couple of simple concepts, and I'll go over those in this video. So evidence-based medicine refers to the practice of caring for patients while using the best available research from the medical literature. And there are four basic elements included in evidence-based medicine. The first one is formulating a clinical question, and we'll talk about what a good clinical question is in a minute. Second element is identifying the best available research. After that, you need to assess the validity of the evidence, and we'll talk about what makes evidence valid or invalid. And then finally, you need to apply the evidence in practice for your patients. So the first element of evidence-based medicine is the formulation of good clinical questions. So let's talk about what good clinical questions are. First of all, they should be focused. You should be very clear on the disease and the intervention you are trying to evaluate with the literature. And then second, they should be answerable from the research literature. To achieve these two goals, most people use what's known as the PICO model for formulating clinical questions. And the PICO model refers to what is the patient population, what is the intervention being considered, what is the comparison intervention group or comparison population, and what outcomes are important. So for example, you need to know whether you're talking about men or women or elderly or young patients. That's the patient population. You need to be very specific about the intervention you're considering. Is it a specific drug, a specific type of surgery? You also need to be clear on what the comparison is. So if you're looking for evidence that a drug works, you need to know in comparison to what? In comparison to a placebo, in comparison to another drug, that's the comparison group. And then finally, you have to clearly define the outcomes. Are you looking for whether a drug has an impact on mortality or whether it has an impact on quality of life? Those are very different outcomes, and you need to define that in order to formulate a good clinical question. So just to make this very clear, here's an example of a bad clinical question. Do ACE inhibitors work for hypertension? This is a vague question. There's no population defined. Are we talking about men or women? Are we talking about elderly patients, younger patients? And there's no specific outcome. It just says, does it work for hypertension? What are you talking about? Are you talking about reducing blood pressure? Are you talking about preventing strokes? We need to define the outcome to make a good clinical question. So here's an example of a good clinical question. Among obese adult women with hypertension, is lisinopril more effective than hydrochlorothiazide for prevention of heart disease? This is the type of question that you can go to the literature and potentially answer by finding research studies. Note that it meets all the requirements of the PICO model. There is a population that's clearly defined, obese adult women. There is an intervention that's clearly defined, lisinopril. We're not just saying ACE inhibitors in general, we're naming a specific ACE inhibitor. There's a comparison intervention, that's hydrochlorothiazide. And then finally, we have an outcome, and that is the incidence of heart disease. The O in the PICO model is for outcomes. So let's talk about some of the different kinds of outcomes that studies in the medical literature will use. Some studies use what are known as hard outcomes. These are called hard because they are easily definable and measurable outcomes. These are also things that are very important to patients. So some examples of a hard outcome would be if a study evaluated the rate of death among patients taking a drug like lisinopril, or the rate of stroke or myocardial infarction or amputation. These are hard outcomes, they're easy to quantify, and they're important in patient care. Soft outcomes, in contrast, are harder to define and measure. These are things like quality of life or improved self-esteem. They may be important to patients, but it's less clear what an improvement in quality of life means, whereas it's very clear what a reduction in the death rate means. Some studies will use what's known as a surrogate outcome. A surrogate outcome is not a hard outcome, but it is predictive of a hard outcome. For example, troponin elevation in and of itself is not bad. However, troponin elevation is a consequence of myocardial infarction, and therefore it's associated with things like death and heart failure that are consequences of myocardial infarction. In the same way of thinking, hemoglobin A1C levels could be a surrogate outcome. A hemoglobin A1C level in and of itself is not bad, but higher levels are associated with more complications from diabetes. Therefore, hemoglobin A1C level could be a surrogate outcome for a study of an impact of a medication on diabetic complications. Okay, so let's talk about why someone would use a surrogate outcome. What are the advantages? Well, the main advantage is that surrogate outcomes are usually more frequent than hard outcomes. This makes them easier and cheaper to obtain. To understand this, imagine a study that enrolled 100 patients and the outcome was mortality. It would take years and years and years for enough deaths to occur to find a significant difference between two groups on two interventions. However, if your outcome is a 10% increase in hemoglobin A1C, you may have that occur in many patients in the time span of just 1 year. This means it's easier to find a significant difference between groups, and it's also cheaper because you don't have to monitor those patients for as long. The disadvantages are that surrogate outcomes sometimes lead to erroneous findings. Just because hemoglobin A1C levels rise or troponin levels rise, it doesn't necessarily mean one of those hard outcomes is going to occur. So sometimes in medicine, we believe that a certain intervention works based on surrogate outcomes, and then a study comes out using hard outcomes and proves that it's not correct. Some studies use what's known as a composite outcome. Composite outcomes are a pool of multiple outcomes, and this is done to increase statistical power. I'll explain what this means in a minute. So this is very popular in cardiology. Many trials of cardiology drugs or angioplasty and surgical interventions use an outcome that is a total of all the deaths, myocardial infarctions, and hospitalizations that occurred in each arm of the study. This increases the statistical power and makes it easier to determine a difference. Let's imagine that we have a study with two arms, each with 100 patients. And let's imagine we follow those patients for 1 year after an intervention. Maybe this group gets a new drug and this group gets a placebo. Well, if our primary outcome were a hard outcome like death, there might be only 1 death in this group and only 2 deaths in this group, and that difference would not be statistically significant. However, if we create a composite outcome that is the total of all the deaths, myocardial infarctions, and hospitalizations in each arm, then what we might have is a situation where we have 10 events in this group and we have 20 events in this group. Now that we have more events, it's more likely this difference will be statistically significant. So we have increased our power to detect a difference between these two groups. The problem with composite outcomes is sometimes one component of the outcome is what drives the whole outcome of the study. For example, there are many studies in cardiology where an intervention shows no change in the death rate, no change in myocardial infarction, but a big change in hospitalization. And because of this one component, the entire intervention turns out to be positive. This can lead to a situation where an intervention is touted as improving mortality, but in reality, it only improved a composite outcome that included mortality, and that composite outcome was entirely driven by the hospitalization rate. Now let's talk about types of evidence. So imagine an intervention like a drug for hypertension comes on the market. The first thing that's going to become available in terms of evidence that this drug works is going to be what's known as primary resources. These are resources that describe outcomes in individual patients, things like case reports and case series, observational studies, and then the best evidence you can have is a randomized clinical trial. After a number of these primary resources have been around, in other words, after there are a number of clinical trials or a number of case reports, you will get what's known as systematic reviews and meta-analyses. These are compilations of primary studies, and obviously these are not going to be available until the intervention has been around for a while. And then eventually, after an intervention has really been around for a long time, usually many years, what's known as society guidelines are written. These are guidelines written by societies like the American Heart Association or the American Cancer Association. And what happens in these society guidelines is experts get together, they review the primary data, the systematic reviews. They also use their clinical expertise and what's known about patient preferences. And based on this, you get a guideline. For example, there is an American Heart Association guideline to give aspirin to all patients with myocardial infarction. This is based on all of these elements here that were around for a long time before the guidelines were written, and the guidelines, therefore, are usually the last available type of evidence to come on the scene. You can also rank evidence from that which is weaker and is more likely to be biased to that which is stronger and less likely to be biased. So basically, the weakest piece of evidence you can have for an intervention on a patient is animal research. If something's been shown to be effective in dogs or rabbits and you cite that as a reason that it's going to work for your patient, that's basically the weakest form of evidence, and there's a high likelihood it will be biased. The next collection of types of evidence that come out are case reports and case series, case control studies, and cohort studies. And these are all observational forms of research. Patients are not randomly assigned to an intervention or a control group, and therefore they are subject to potential bias. The best type of evidence you can have is a randomized controlled trial. These are expensive and difficult to conduct. They're not available for every intervention in medicine, but when they are available, these tend to be the best type of evidence you can have. And that's because patients are randomly assigned to an intervention or not, and therefore that eliminates most forms of bias. And then once there are a number of randomized trials, you can find systematic reviews of trials, and meta-analyses of trials. These are all randomized types of data, and the more of them you have, the more powerful your evidence is. Now let's talk about evaluating evidence. So let's imagine you find a study on patients taking lisinopril compared to patients taking hydrochlorothiazide, and you want to know whether that study is valid and can be applied to a particular patient in your clinic. Well, the first thing you want to think about is the internal validity of that study. An internal validity of the study basically means, was the research conducted properly? Are the conclusions correct? Is there bias, or are the results due to chance? So what you're going to do here is you're going to look at the results of the study and say, were those data collected properly? Were the correct conclusions drawn? Is there any possibility that the people who conducted the study made a mistake when assessing the outcomes? These are all things about the internal validity of a study. Basically, is that study properly conducted or not? The second thing you want to look at is the external validity of a study. So this has nothing to do with how the study was conducted, but it has to do with whether or not the research applies to patients not in the study, like maybe the patient in your clinic. So you want to ask questions like, are the study patients similar to real-world patients? Is this intervention similar to real-world interventions? And does this study apply to the patient in my clinical question? For example, in heart failure, the average age of patients in most trials is about 60 years old. In actual practice, the average age of patients with heart failure is about 80 years old. So in cardiology, we often talk about, do those heart failure studies have external validity? Meaning, does that research conducted on younger patients apply to the actual population of older patients in my clinic? As another example, in many clinical studies, research nurses will check on patients every week or sometimes every day to make sure they take their medication. Obviously, that doesn't happen in real life. So we sometimes question whether or not a study has external validity, because in real life, patients aren't able to comply with the medicines the same way they were in the study. These are all examples of evaluating the external validity of research. And I'll finish this video with this slide. So evidence-based medicine says that not only do you need to identify the best evidence, but you also need to use your clinical expertise, and you also need to factor in the patient wishes. So for example, in my own practice, I often know what the evidence recommends, but I will use my clinical expertise to decide whether or not this applies to a particular patient based on my experience. In addition, sometimes the evidence will say that a certain thing works, but we will discuss this, myself and my patients, and determine that based on their wishes, they don't want to have that particular intervention. So this is another way of factoring in patient wishes, just like we factor in clinical expertise. And so these three elements together are combined into what's known as evidence-based medicine. And that concludes our video on evidence-based medicine.